Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. And this is a 72-year-old gentleman diabetic with a grade 3 nuclear sclerosis. And in this case, we did a direct horizontal chop under topical anesthesia. The case went about just as a routine, but then in the end I had to enlarge the capsular axis. So let's see how it went about. So by now the incisions have been made, the dye has been put to stain the anterior capsule, and now is the time to create a rhexis. So a flap is created with the help of a 26 gauge bent cystitome and with the help of a utrata. The aim was to create at least a 5.5 mm of rhexis, but the rhexis came out to be a bit on the smaller side as I had expected. Nevertheless, was good enough to continue with the phaco. The nucleus rotated pretty easily. And we went in with the probe, bevel down. This is cataract 3 phaco machine. After removing a bit of the cortex, the bevel is turned up, and time to introduce the karate chopper. This has a blunt tip and a sharp inside edge. So just proximal or subincisional. The probe is buried in the lens mass, moved a bit towards the center, and the chopper goes to the far periphery and we get a good crack. Now rotating and going to the opposite pole, and we have two heminuclei. Now going deep into these heminuclei, getting a good hold, and this chopper goes to the far periphery and we get a good crack again. Now is the time to deal with the other heminucleus. So the trick is to bury the probe, get a good hold first, and then take this chopper to the far periphery, bring it towards the probe and just laterally separate them, and we get a good crack. So now we have 4 pie shaped quadrants, and now is the time to emulsify them one by one. So we are bringing up each quadrant and slowly emulsifying it in the central safe zone and at the level of the iris to avoid endothelial damage. So by now one heminucleus has been dealt with. Now this third quadrant is brought up, split again, and then slowly emulsified. Chamber stability is excellent with this Oertli machine, no financial interest. Even in the last piece, the chamber stability is excellent, but to be on the safer side, the parameters are now reduced and the chopper goes in the safe position behind the probe, making sure that the posterior capsule doesn't come up. This last nucleus bit is removed over this epinuclear shell, making it a bit more safe. Now trying to lift this pole of the epinucleus, but it's better to roll it over, and just with vacuum this epinucleus is removed and the nucleus is managed. Now with this 22 gauge Simcoe cannula, the cortical matter is washed off pretty quickly. This red glow gives us a good contrast and depth, so helps in this cortical wash. Now with the going in through the side port and cleaning the subincisional cortex, and in no time this cortical wash is done. Now is the time to inject the IOL. It's a wound assisted delivery. The leading haptic goes in the bag and then the trailing haptic is dialed in. It's a hydrophilic IOL. Now once this IOL goes in the bag, I realize that the capsulorhexis is on the smaller side, so it's better to enlarge this rhexis. So with the help of Avanas, a nick is made over the anterior capsule, and with the help of the rhexis forceps, the capsule is held and a rhexis is created. So now it's pretty good and it will work. And now is the time to thoroughly clean the anterior chamber, going behind the IOL, cleaning all the visco from the bag, to avoid any intraocular postoperative IOP spikes. And that's it. So the take home message is, keep everything very simple and give in your best. So now is the time to hydrate the wounds. The chamber is made tight, water sealed, and that's it. The case is done. I hope you like this video. Thank you for watching.